Andrew, the label on Sterol-enriched spreads and capsules makes it sound almost mechanical. Eat this, block cholesterol, lower LDL. Is that basically true, or is the marketing compressing three different things into one slogan?
The short version is, yes for modest LDL lowering, no for miracle framing. Plant sterols and stanols look enough like cholesterol that they interfere with cholesterol handling in the gut. Across randomized trial reviews, the LDL drop is usually moderate, roughly a quarter to a third of a millimole per liter in many summaries, not a statin-sized reset. The mechanism starts before the bloodstream. Picture bile as the body's dish soap. It packages fats and cholesterol into tiny mixed micelles so the intestinal wall can absorb them. Plant sterols enter that crowded package and push some cholesterol out. Less cholesterol reaches enterocytes, so less is delivered onward, and the liver often responds by pulling more LDL particles from blood to maintain its cholesterol balance.
So timing and format matter, right? If the action is happening in the gut while fat, bile, and cholesterol are being mixed, does a capsule swallowed randomly behave the same as sterols built into a yogurt, spread, grain bar, or drink?
Exactly. The evidence base includes sterols or stanols in fats and oils, dairy, grains, drinks, mixed foods, and supplement forms. That tells us the biology is not limited to one branded spread. But it also means product comparisons are messy. A tested enriched food is not automatically the same as any bargain capsule with vague labeling or a multi-ingredient blend. The dose-response analysis is useful because it shows LDL reductions of at least about 0.2 millimoles per liter, even around 0.5 to 1 gram per day, with greater intake tending to lower LDL more. But this is not an infinite lever. More sterol does not mean endlessly lower LDL because micelle capacity, intestinal transport, and liver compensation all have limits.
Who is this actually for? Someone with already excellent LDL probably should not chase a tiny number, but for mild hypercholesterolemia or family risk people who are already working on diet, is it a reasonable add-on rather than a standalone plan?
Reasonable add-on is the right phrase. If a clinician has recommended lipid-lowering medication because someone's risk is high, plant sterols should not quietly replace that plan. Dietary supplements can interact with medicines, vary from study products, and create false reassurance. They belong in the conversation, especially before surgery, pregnancy, complex disease, or medication changes, not outside it.
The review also lists ApoB, HSCRP, blood pressure, BMI, even Lp(a). Should viewers hear that as broad cardiometabolic improvement or as small statistical ripples around the main LDL finding?
I would call most of those as secondary signals interesting, not the headline. ApoB improved by about 0.06 grams per liter in the umbrella review, which fits the idea of fewer atherogenic particles. Blood pressure changes were around 1 to 2 millimeters of mercury. BMI shifted by about 0.06 kilograms per square meter. Those are not weight loss, inflammation cure, or hypertension treatment claims. And several things did not clearly change. HDL-C, fasting glucose, HbA1c, body weight, waist circumference, fat mass, and multiple inflammatory markers. That negative space matters. It keeps plant sterols in the LDL-lowering lane instead of turning them into a general metabolic wellness badge. If a product promises glucose control, belly fat reduction, and cholesterol repair from sterols alone, it has outrun the evidence.
Here is the uncomfortable boundary. LDL is causally important in cardiovascular prevention, but did plant sterol trials actually prove fewer heart attacks or strokes, or are we using LDL as a reasonable but still indirect endpoint?
That is exactly the boundary. The evidence is strongest for the lab marker, not for direct clinical outcomes. That does not make the LDL effect meaningless. LDL-C and ApoB biology are central to atherosclerosis risk. But it does mean we should not pretend every way of lowering LDL has already demonstrated the same event reduction evidence as therapies tested in outcome trials. So if someone tries sterols, The honest test is a lipid panel, not a feeling. Keep the rest of the diet and medication plan stable. Use a consistent dose with meals, and recheck LDL-C after a reasonable interval. If the number barely moves, the issue could be the product, adherence, baseline cholesterol absorption, or simply expectations that were too large for the tool. Product quality deserves boring attention. A recent phytosteroid supplement study, not about cholesterol sterols specifically, found huge label versus content discrepancies. The lesson carries overcautiously. Supplements are not automatically equivalent to their labels or to trial materials. Choose reputable products. Avoid proprietary mystery blends. And be skeptical when sterols are bundled with many ingredients and advertised as stronger than the evidence. That combination point is not theoretical. One randomized trial tested a capsule blend with plant sterols, bergamot, artichoke leaf, and hydroxytyrosol in adults with mild hypercholesterolemia and did not find a significant LDL advantage over placebo. That does not erase the broader sterol literature, but it warns us that stacking ingredients does not automatically add benefits. Sometimes a complex formula makes the result less predictable.
What are the real safety edges, not the dramatic internet ones? I keep seeing concern about fat-soluble nutrients and rare people who absorb plant sterols abnormally. How should someone separate ordinary food exposure from concentrated products?
The practical answer is proportion. Normal plant foods contain small amounts of sterols as part of a diet. Enriched foods and capsules are deliberate cholesterol-lowering tools. If using those tools, eat plenty of colorful produce to support carotenoid intake. Avoid concentrated sterols if you have cytosterolemia unless a specialist directs otherwise, and judge success by LDL-C. Plant sterols are plausible and evidence-backed for modest LDL lowering, but they are not proof of fewer events, not a weight loss product, and not a reason to ignore a clinician's cholesterol plan.